Over 70% of women going through perimenopause and menopause report waking up with sudden, widespread aching in their joints. The stiffness usually hits hardest in the morning. A deep, persistent ache settles into the hands, wrists, hips, and knees, yet there is no visible swelling, no redness, and no recent physical injury to explain why it hurts to simply get out of bed. When these symptoms are brought to primary care, the common clinical response is often a diagnosis of standard osteoarthritis or a suggestion that these aches are simply part of getting older. But standard osteoarthritis causes localized wear and tear that stays in one place. This pain migrates. It moves unpredictably from the knees one week to the wrists the next. And when doctors order standard X-rays to look for structural damage, the imaging almost always comes back completely normal. Only recently did researchers formalize a medical term for this exact pattern. They call it the musculoskeletal syndrome of menopause. It describes a specific collection of migrating joint pain, cartilage damage, and inflammation linked directly to hormonal decline. The migrating pain is a highly specific systemic condition triggered entirely by a shifting endocrine system. To understand why a hormonal shift makes your knees hurt, we have to look at what estrogen actually does in the body. While it is primarily known as a reproductive hormone, estrogen operates as a master regulator of systemic inflammation. Estrogen receptors are embedded directly inside joint cartilage, synovial membranes, and bone. Binding to these receptors creates a biochemical shield, actively suppressing pro-inflammatory cytokines like IL-6. Estrogen also supports hyaluronic acid, keeping synovial fluid thick to prevent bones from rubbing together. When perimenopause begins, estrogen levels drop sharply. Within months, that chemical shield disappears. Without estrogen, inflammatory IL-6 spikes unchecked, triggering systemic inflammation. Simultaneously, protective synovial fluid thins out, drastically increasing friction inside the joint. The sudden onset of joint pain is caused by the abrupt biochemical removal of the body's primary joint lubricant and anti-inflammatory shield. Biological friction is only half the problem. As estrogen withdraws, physical support structures surrounding the joints begin to fail as well. During perimenopause, women lose an average of 10% of their bone mineral density. Compounding this, they begin losing approximately 0.6% of their muscle mass every single year. Muscles stabilize movement, and dense bones absorb shock. When those physical supports weaken, the increased mechanical load transfers directly onto the already inflamed, poorly lubricated joint cartilage. We can see this in clinical data. This chart illustrates the Women's Health Initiative trial, tracking over 10,000 postmenopausal women assigned to daily estrogen or a placebo. Researchers found a sustained, statistically significant reduction in joint pain exclusively among the women receiving estrogen. Reversing the joint collapse requires a strategy that replaces both the missing biochemical signals and the lost physical support system. For women who are not candidates for hormone replacement therapy, or who choose not to use it, the lost functions of estrogen can be replicated through targeted clinical nutrition and mechanical intervention. The first step is replacing the biological shield. The botanical ashwagandha acts as a direct countermeasure to the unchecked inflammation by specifically suppressing the IL-6 cytokine pathway that estrogen left exposed. To address the joints directly, black cohosh modulates estrogen receptors. It partially binds to these receptors within the joint tissue, effectively tricking the body into restoring a portion of the missing anti-inflammatory signal. This biological defense is reinforced by DHA omega-3s and magnesium glycinate. Together, they actively resolve cellular inflammation and support the overnight tissue repair cycles that are frequently interrupted by menopause-related sleep disruptions. But clinical nutrition only solves the biological half of the equation. To stop the mechanical damage, the lost structural stability must be actively rebuilt. Resistance training is an absolute necessity. Loading the muscles and bones with external weight is the only proven method to rebuild the muscular shock absorption and bone density that estrogen used to maintain automatically. Meeting the biological transition of menopause with a sophisticated toolkit of targeted botanicals and strength training allows women to fully restore their fluidity, strength, and lifelong mobility.